Hello everyone. Today in this video, we are going to discuss about how to diagnose a congenital cyanotic heart disease. When a child comes to your outdoor or your emergency with a cyanosis, then you have to differentiate the cyanosis into two types. That means either the cyanosis is peripheral cyanosis, that means bluish discoloration on the periphery, that means limbs, or is it a central cyanosis, that means cyanosis in the lips or tongue and generalized cyanosis. So after diagnosing the child having central cyanosis, then you have to divide it, this central cyanosis, cause of central cyanosis, into four different types, because the etiology of central cyanosis having some different causes. So firstly is the respiratory system which causing central cyanosis, the cardiological cause which causing central cyanosis, some hematological cause which causing central cyanosis, and some other causes, idiopathic causes which causing central cyanosis. So how to diagnose this cyanosis, central cyanosis due to cardiological cause? In this video we are going to discuss about this, because if we are not able to diagnose the central cyanosis is due to respiratory cause, then we miss the severe problems. So you have to differentiate between respiratory, the cyanosis either due to the respiratory or cardiological cause or hematological cause or etiological cause, and peripheral cyanosis is due to cold exposure. Now, what is cyanosis? That is bluish discoloration of the body due to much more hematological, much more deoxygenated blood is present in the blood, and the amount of deoxygenated blood is more than 5 gram per dl. If more than 5 gram per dl deoxygenated blood present in the blood vessels, then the patient present with cyanosis. Now, how to differentiate between these four types, I will discuss on my next slide. So when you are suspecting a child or a neonate with cyanosis, then you have to do three things. When you are suspect a newborn or a patient with having cyanosis, then firstly you have to differentiate this cyanosis into that either, as I said, central cyanosis or due to peripheral cyanosis. When their tongue is cyanosed, that means it is central cyanosis. When the lips are cyanosed but the tongue is not bluish, that is peripheral cyanosis. After diagnosing that is a central cyanosis, you have to check the CBG, because due to the hypoglycemia there may be a chance of either cyanosis, and to confirm the cyanosis you have to do pulse oximetry. So routine pulse oximetry check is very much important for every child, because if we are we does not check the saturation by the in the pulse oximeter, then we can miss the cyanosis, mild degree of cyanosis, and this the child may lead to some congenital cyanotic heart disease. So every patient, every child borns after every newborn which is born, and after 24 hours we have to do a saturation checked by the pulse oximeter, and this saturation check on the right arm and left leg, and we have to check all the four limbs if it is feasible. Mostly we have to check all the four limbs. If it we have to check in two limbs, then right arm and left leg is the normal checking point where we check the saturation. Then after diagnosing the child having the pulse oximeter showing the child having cyanosis, then we have to check the bilateral femoral artery pulsation. If the bilateral femoral artery pulsation is not there, it is absent, then we think about coarctation of aorta. And after that we have to do the hyperoxia test. This test is divided this cyanosis into either due to respiratory cause and cardiological cause, because this test divided this cyanosis and cleans the diagnosis of either due to the respiratory cause or due to the cardiological cause. And if the CVG is less than 50, then this cyanosis is maybe due to the hypoglycemia, or the child may having polycythemia. I will discuss on later on. So when you are suspecting a newborn having cyanosis, or any newborn which is born after who born any newborn after 24 hours, we have to do pulse oximetry and check the saturation in all the four limbs. So after 24 hours, we have to check all the saturation of all the four limbs. Mostly the right hand and the left foot is much more indicated, because the right hand shows preductal, as this is the heart, this is the aorta. Then aorta is connected with the pulmonary artery, after the right subclavian artery, and this is the pulmonary patent arteriolus, ductus arteriosus, and this is after the right carotid artery. So right arm is showing the preductal saturation and the legs are showing the postductal saturation. So preductal and postductal saturation, it is done by seeing the right arm and left leg. So after, when we are doing the saturation check, if the pulse oximeter saturation is less than 89 in any patient, then the child is suffering from congenital cyanotic heart disease and we have to do the echocardiography. So if the pulse oximeter is showing saturation is less than 89% on right hand or left hand, it is less than 89%, then the child having some congenital cyanotic heart disease and we have to do echocardiography as early as possible. After that, if the saturation is in between 90 to 94% on both the right arm and the foot, or the right arm having saturation like just like 94%, but the left leg is saturation having 90%, that means there is a 89%, sorry, 95%, and it is 90%, then there is a gap difference between it is more than 4%. If the difference between the right arm and the foot is more than 4%, then the child may have some congenital cyanotic heart disease. So we have to repeat after 1 hour. But if the saturation is more than 95% in both the right arm and left foot or any foot, and the difference is less than 3%, then the child does not have any congenital cardiac heart disease or congenital cardiac problem. Now, if the saturation is in between 90 to 94% or the saturation difference between right arm and the left leg is more than 4%, then after 1 hour we again check the saturation. And if the saturation shows the saturation is less than 89% in either right arm or right foot, or then the child is suffering from congenital cyanotic heart disease. If again it is showing that the saturation is 90 to 94 and it is more than saturation difference is more than 4%, then again we have to do the pulse oximetry after 1 hour. And if the saturation is more than 95% in both the right hand and foot, and the difference is less than 3%, then the child is having normal heart. After 1 hour of saturation, checking the saturation, if it is less than 89%, then we do the echocardiography as the child is suffering from congenital cyanotic heart disease. If the difference again between 90 to 94% and or the difference is more than 4%, that means the child is suffering, may or may not have some congenital cyanotic heart disease. So we have to do the echocardiography. And if the saturation is more than 95%, then the child does not have any congenital cyanotic heart disease. So this is the neonatal screening of pulse oximetry after delivery, 24 hours of delivery. Now, Hyperoxia test. So Hyperoxia test. So when a cyanotic child is present to an emergency and the saturation shows the child having cyanosis, and you are not able to differentiate between the cyanosis is either due to the respiratory cause or the cardiological cause, then we have to do the Hyperoxia test. And this test is done, it is an invasive procedure. So how this test is done? We have to take an ABG before giving the oxygen. So we have to take an ABG and see the partial pressure of PaO2. And after taking the ABG, we have to give 10 minutes of oxygen, 100% oxygen by the either oxygen hood, or if the child is in ventilator, then we have to give 100% FiO2. After 10 minutes, we again do the ABG. And if the ABG, we have to see the PaO2. If the PaO2 is more than 150, and if the PaO2 is more than 150, or the difference between the previous PaO2 and the recent PaO2 is more than 50%, then it is diagnosed as the cyanosis due to respiratory cause. So this is a pulmonary cause because the PaO2 is more than 150 and or the rise is more than 50%. It is more than 50%, then it is due to some respiratory cause. But if the PO2 is not more than 150%, that means 100 to it is rise less than 100, then it is a clear-cut diagnosis of having some congenital cyanotic heart disease, or it is in between 100 to 150, or and the difference is less than 20 to 50%, the child may either having some primary PPHN, that means persistent primary hypertension, pulmonary hypertension, or either due to cyanotic heart disease. But if the PO2 is less than 150, if the PO2 is less than 100, and the difference is less than 20%, then it is a clear-cut diagnosis having some congenital cyanotic heart disease. But if the difference is between 20 to in between 20 to 50 and the PO2 is 100 to 150, then either the child may be having some congenital cyanotic heart disease or PPHN, that means persistent primary pulmonary hypertension. So why this saturation is increased? Because if the respiratory cyanosis is due to respiratory cause, then when you give the oxygen, then saturation is increasing, because the oxygen is the respiratory cause. The main cyanosis is due to oxygenation problem. But in case of congenital cyanotic heart disease, that means right to left, the cyanosis is due to a right to left shunt, because as the heart is like this is the right and this is the left. These oxygenated blood which is present in the right side when enter into the left side, and there is a mixing, that is then there is a cyanosis. So right to left shunt, the mainly oxygenated blood is presented if we give more and more oxygen, but the mixing is there, so there is a no change in the saturation. So this is then when how to diagnose between, how to differentiate between the PPHN and the congenital cyanotic heart disease. We give the hyperventilation test. What is hyperventilation test? Again, we are giving 100% oxygen for more than 1 hour. So we are giving 100% oxygen with the face mask or with the intubation or oxygen hood for 1 hour, and after that we check the PO2. If the PO2 is more than 150, then it is PPHN. If it is less than 150, then it is congenital cyanotic heart disease. So why? Because when you are giving 100% oxygen for 1 hour, this oxygen causing vasodilatation of the pulmonary belt. So due to the vasodilatation, there is an increased oxygenation and decrease the pressure of the lung. As the pressure of the lung is decreased in persistent primary pulmonary hypertension, as the pressure is increasing, so less amount of blood getting into the lung, so there is a less oxygenation. As because of the vasodilation, the more amount of blood enter into the lung and causing increased oxygenation, and that's why there is a increased saturation. So that's how we are dividing this PPHN, differentiated between PPHN and congenital cyanotic heart disease. So after diagnosing the child having congenital cyanotic heart disease, how we are diagnosing the child having congenital cyanotic heart disease? By 3 tests. That is, check the saturation. If the saturation is less than 89%, then we are doing the hyperoxia test. If the child having hyperoxia test positive, that means the child having congenital cyanotic heart disease. Then we divided patient having congenital cyanotic heart disease into 2 types, based on the pulmonary blood flow and also based on the duct dependency. So congenital cyanotic heart disease is divided into 2 types. One is increased pulmonary blood flow and decreased pulmonary blood flow. If the pulmonary blood flow is increased and the child having cyanosis, that means there is a plethoric lung and also increased amount of blood into the lung, and there is a mixing is much in the right side, and also there is a no pulmonary artery stenosis. If the pulmonary blood flow is decreasing, that means there is a pulmonary artery stenosis is there. So what are the causes of increased pulmonary blood flow? That is Epstein anomaly, syndrome, or TGA, transposition of great artery, or due to, or there is a TA, tricuspid atresia with VSD, without pulmonary artery stenosis, without PS. Fourth is TA PVC. And decreased pulmonary blood flow, mainly the cause is TOF, tetralogy of Fallot, because there is a pulmonary stenosis is there, or there is a tricuspid atresia with VSD with PS, or TGA with PS. These are the causes of decreased pulmonary blood flow. Why this is important? Because if there is an increased pulmonary blood flow, so there is a right chance of increased right heart failure. So we have to give diuretics for the child. And if the pulmonary blood flow is low, then no need of giving diuretics. Diuretics will hamper the child. Now, depend on the duct dependency. Either the cyanotic heart disease is due to duct dependent or duct independent. Why it is very much important? Because if it is duct dependent, we have to make patents of the duct. So the causes of duct dependent and duct dependent circulation is either Epstein anomaly or tricuspid atresia, TGA, and duct independent circulation is TOF and TAPVC. So we have to divide it into these two type of cyanotic heart disease, and the definitive investigation to diagnose all these cyanotic heart disease echocardiography with 2D echocardiography with scalar Doppler. So that's how you have to diagnose or suspect a patient having cyanosis. Thank you.